Take two 2-year-old patients exhibiting the exact same physical symptoms, fever and a persistent cough. This diagram maps the timeline divergence. Patient A receives immediate clinic care. Patient B endures a 4-day delay, ending in an emergency. Patient B's family utilized herbal remedies out of calculated decisions based on established community beliefs and the immediate fear of lost wages. A medically flawless prescription is biologically useless if the patient cannot afford it, understand it, or execute it. To practice medicine effectively, we must construct a framework diagnosing patient behavior using social psychology and mapping available safety nets through social protection schemes. Early medical training often frames a patient's failure to follow instructions as simple ignorance. Mastering medicine requires diagnosing the structural realities of a patient's life with the exact same rigor used to diagnose their physiological pathology. Social psychology in clinical practice approaches the patient as a complex node within a family and community network, rather than an isolated case of disease. This triad network illustrates the ABC model of attitude, which explains patient decision-making. Take a diabetic patient who actively avoids their prescribed insulin regimen. The affective component represents the emotional response. Here, it is the visceral fear of daily injections. The cognitive component is the patient's underlying flawed belief system, such as the conviction that requiring insulin means their organs are failing. The behavioral component is the inevitable action resulting from the previous two nodes, the complete avoidance of the medication. Shifting from internal beliefs to external pressures, we must account for motivation. Health is rarely a vulnerable patient's only priority. Consider a daily wage worker who refuses a diagnostic tuberculosis test because missing a single shift means his family goes hungry. He cares deeply about his health, but immediate survival needs outrank long-term medical needs. Labeling this patient non-compliant ignores the clinical reality. Effective treatment requires addressing the emotional and motivational root causes alongside the medical symptoms. When confronting a difficult diagnosis, the mind relies on defense mechanisms, automatic, unconscious tools designed to reduce severe anxiety. This grid visualizes those responses. In denial, a patient entirely rejects the reality of a positive biopsy. In projection, a frightened patient directs their internal panic squarely at doctors. Sublimation is the redirection of medical stress into a productive action. These mechanisms function as common, temporary shields to protect self-esteem during crisis, distinct from permanent psychiatric conditions. A physician reacting to a patient's denial with frustration is medically counterproductive. Recognizing the defense mechanism is the first necessary step to dismantling it with time and cognitive correction. Physical disease inherently damages a family's financial future, draining savings and halting educational prospects. Existing poverty leads to poor nutrition and unsafe working conditions, heightening the risk of chronic and infectious disease. Sudden illness then causes immediate wage loss and forces the sale of assets, plunging the family deeper into poverty. Social protection is the macroeconomic intervention explicitly designed to interrupt this devastating feedback loop. This concept divides into two distinct legally defined pillars that govern how state support is funded. Social insurance is a contributory fund. Both the employee and the employer must proactively pay into it. The primary example is the Employee State Insurance, or ESI, which relies on a combined 4% wage contribution. ESI protects industrial workers by providing direct medical care and vital cash support during certified periods of sickness or injury. The second pillar, social assistance, is non-contributory. It provides need-based support entirely funded by the state for highly vulnerable groups, such as old age or widow pensions. Without these two financial safety nets, a single severe medical emergency triggers a multi-generational economic collapse for a family. The largest non-contributory health assurance scheme in the country is Ayushman Bharat PMJ. This graphic outlines the core specifications of PMJ. It provides up to 5 lakh rupees of health cover per family per year, aimed at the poorest demographics. The scheme targets secondary and tertiary care, advanced procedures, surgeries, and specialized hospitalizations. The operational benefits are cashless and portable. Patients face zero out-of-pocket costs at the point of service at any impaneled hospital nationwide. Contrast this with CGHS, a specialized health service benefit restricted to central government employees and pensioners. PMJA targets catastrophic debt from major hospitalizations. It leaves primary care and routine outpatient treatment to the existing public health infrastructure. State schemes save families from financial ruin during major surgeries, but the physician's role in early prevention, primary care, and health education remains the irreplaceable frontline defense. Consider a 52-year-old industrial worker suffering from severe diabetes who has developed a critical foot ulcer. He is actively delaying hospital admission, risking severe infection and ultimate amputation. This decision tree systematically maps his clinical challenge. Before operating, we evaluate the psychological barriers driving his delay using the ABC framework. His flawed cognitive belief that stepping into a hospital guarantees he will lose his limb fuels his effective terror. We then map the economic barriers. Entering the hospital means his daily wages stop, starving his family. We map the structural solution by checking his employment status for ESI eligibility, which guarantees medical treatment and wage support. If he falls outside ESI coverage, the physician checks his vulnerability status for PMJ to cover the catastrophic costs of a potential tertiary-level surgery. This is the four-step mandate for the modern physician. Treat the pathology medically, counsel the psychological attitude, identify economic barriers, connect the patient to structural support systems. Social psychology and state protection schemes serve as the primary delivery systems for medical intervention. Without them, the most advanced treatments never reach the patient.